Hello, everyone. Welcome to the first episode of the international edition of The Art of Drug Choice, Vet AMD and the Latest Data. I'm your host, Arshad Khanani, and it's my great pleasure to have esteemed international faculty here today with me, Dr. Peter Kertes from University of Toronto, Canada. Hi, Peter.
Hi, Arshad. Thank you.
We also have Justus Garweg from University of Bern, Switzerland.
Hi, Arshad.
And we have Dr. Seenu Hariprasad from University of Chicago.
Thank you so much, Arshad. It's a pleasure to be involved in this.
This is episode 1 of 4. Today we'll discuss tactics for switching wet AMD patients to different drugs and also review a case with Dr. Garweg. In future episodes, we'll discuss phase 3 data, real-world data, pipeline candidates, and we'll wrap up the series with a discussion on safety. For now, let's get into a review of therapeutic options for wet AMD. Peter, now that there is another anti-VEGF option to select, which is brolucizumab, have you found that you are more willing to switch your wet AMD patients to a different anti-VEGF agent?
That's an interesting question. Unfortunately, much of what we do is driven by reimbursement. So in Toronto, which is in the province of Ontario where I practice, so far brolucizumab hasn't been reimbursed. So it's been relatively difficult and slow to switch patients from their current therapy, which is by and large aflibercept, to brolucizumab. But certainly, I have many patients who need frequent dosing of their aflibercept that I have switched to brolucizumab, and many more that I'm eager to give brolucizumab a try and to see if I can extend those patients a little longer and stretch out their visits. But of course, I'm always a bit cautious given the inflammation data that we're seeing with brolucizumab.
Thanks, Peter. Those are great points, and it's so nice to have all of you here because we can get different perspective today. And brolucizumab has been available in the U.S. Since October of 2019, and of course, we're going to deal with safety in our last episode. Just as you have been an early adopter in Switzerland, you presented some impressive cases and taught all of us about managing these patients. So tell me how you're treating your patients currently with wet AMD, and when do you decide to switch to brolucizumab?
Basically, we have not changed our attitude. We are unhappy if the retina is not stable. And namely, if you see a patient with a better or an only eye, you want to have the patient dry. So you have a patient on a drug which is not working, or the patient has a very high treatment demand, then you would consider switching to another drug. And then you take all opportunities you have. If you have the patient on Lucentis, you would switch probably in the current situation to aflibercept, and from aflibercept to brolucizumab. But if you have a patient with a history of having had everything, you go right away into new treatment options where you have a chance to stabilize the situation, namely in a patient who is expecting quite a way to go until coming down with his vision.
Thanks, Justus. So it sounds like the goal is disease control based on OCT, and all of us are trying to make sure that the retina is as dry as possible while we are decreasing the treatment burden on patients with wet AMD. So Seenu, I know you have been involved with all the clinical trials and presented data for all of them, and you have a very busy practice at University of Chicago. So when you have a patient with wet AMD and they're coming in monthly and they have uncontrolled disease and their vision is sliding, what do you do for that patient currently?
I think this past year and a half, more than ever in history, has made us reevaluate how we're treating patients with the COVID pandemic. That there were times during the past year, I didn't know when the next follow-up would be for these patients. And so every patient that comes in on older generation therapies, we do an evaluation about whether we should switch the patient or continue what we're doing. And for each patient, it's simply a balance between this ultra rare adverse event profile of brolucizumab, catastrophic inflammation that leads to vision loss, versus there's minimal controversy that brolucizumab has a very strong drying effect of the retina. And so that this balance is something that we think about in each and every patient, and we do switch if patients had multiple Eylea, Avastin injections, and they just have persistent fluid, God forbid the vision is getting worse, or even if the frequency of visits are too high, we absolutely will switch. And of course, there's a very good discussion with the patient and informed consent. And we will switch to brolucizumab if it's a sensible thing to do in that particular patient.
I think those are really good points, Seenu. I think with COVID-19, we have all seen how patients miss their visits and then their vision ended up poor, whether there was a bleed or poor disease control. So Peter, how did COVID impact your practice in Canada, and what are the things you did to kind of help your patients with wet AMD? For me, it was we did operate. We just did injection only visits and really got the patients in and out, but we really didn't stop. But there were patients who didn't want to come in, and then when they kind of came 3 months later with a bleed, we had irreversible vision loss. So as Seenu mentioned, I think we learned that we need agents that have better durability and better drying effect to control the disease. What did you do in Canada during COVID?
Yeah, I had a very similar experience. I mean, we had periods of time where we were shut down really to all elective stuff, but our AMD patients who needed active ongoing therapy would still come in. So we worked pretty hard to get them in and out as quickly as possible. Many patients that had sort of an established interval of stability that was reasonable in length, we would just sort of, we would get them in, take a quick look and do the injection and get them out and forego some of the diagnostic testing that we were accustomed to. There are patients that sort of extended themselves. So, you raised a good point where patients were afraid to come in and reluctant to come in. And many of those patients did come back with catastrophic and irreversible vision loss, but many of those patients came in, after a long interval, fairly stable. So they sort of, they showed us that their interval that had been set previously maybe wasn't aggressive enough and they could go longer. So we certainly saw both sides of the coin. It was unfortunately to see those patients that had lost vision, but there are many patients who had established a longer interval that have continued on that longer interval.
Peter, those are great points, and I agree with you. I think I've had some patients who were getting treatment every 6 to 8 weeks, and then they missed a few appointments and came 4 months later, and they have minimal fluid. So I think it tells us that it's a very individualized disease, and the treatments need to be individualized to cater to the patients. And of course, Peter, you have done excellent work on that and published that. So Justus, has the vaccination rates have gone up, at least in the US. How about Switzerland? How are things in Switzerland? And has that impacted, your practice, meaning you have more and more patients coming in to get their treatments?
Well, it's interesting. In Switzerland now is 57% of individuals having been vaccinated twice. So there's quite some safety. But our patients, namely the elder patients, they lost their fears. They learned how important it is to work together. They were more reluctant to go to their GPs and family doctors than coming into us because they learned they need the treatment. And this did not change with the progress in vaccination. Basically, patients do fear more in Switzerland to lose vision, to go blind, or to lose their driving licenses than attracting COVID. So it didn't make such impact. In the early 3 months, yes, but not thereafter.
Yeah, I think that sounds like the similar experience here in the US. Seenu, how has your practice changed after COVID? So before COVID, we were doing certain things. COVID taught us that we need better durable agents, and a lot of patients need their treatments, and some of them can be extended. So any learnings for the audience from COVID, especially as, the leader at University of Chicago and doing training for a lot of residents and fellows, and taking care of all the patients there.
You know, it's really funny. We learned a lot from the COVID experience. You know, what we've been through psychologically, mentally, ourselves, our patients. It really was a remarkable year. It was a horrible year. I wish it never happened. But you can't go through this without learning something. And you know, it's really amazing how few patients, you know, did very poorly. That there were a handful. There's no doubt about it. But there were many patients who actually did okay with increased frequency of injections. And so we had a discussion, myself and my trainees, that are we overdosing? Are we over-treating these patients? And we came up with the conclusion that it is okay to overtreat to prevent a small portion of patients, you know, falling through the cracks and having catastrophic vision loss. And I think that's, it was very educational to us to see what happens without the frequency of dosing that we're accustomed to. And I do believe as a community, we are overdosing a little bit, but you know what, that's okay. And, you know, because it's good to bring in these patients, it's good to look at the fellow eye, make sure the fellow eye didn't convert, you know, and the treat and extend strategies are excellent. But I think that's one thing that we learned. The other thing that we learned is not to be scared by ultra rare catastrophic inflammatory events. And brolucizumab saved us. And, you know, as an institution, we don't have the ability to flex the way you all do in private practice. And it's very different. I mean, we had to follow the institutional guidelines, and our volumes were slashed in terms of patient volumes. So, you know, we're in survival mode, and we use a lot of durable agents, whether it's Ozurdex, Iluvien, brolucizumab. We really leaned on these agents to get us through these difficult times when there were some days, you know, I typically see 65, 70 patients a day. We were seeing 6 or 7 patients a day. Can you imagine the catastrophic cut in the volume? So, so really, we leaned on these more durable agents, and God willing, we didn't see anything bad happen. And but it gave us the muster that it's okay to use some of these agents. And frankly, brolucizumab is not the only agent in the pipeline that has you know, an adverse event profile that we need to think about. So there's a whole generation of drugs in the pipeline that are not perfect from an adverse event profile. And frankly, the community has to learn how to deal with this, and how fortunate we are to have such safe drugs that were approved early on in the treatment of these diseases, you know, from 2004-05 onward.
Seenu, those are excellent points. And I agree, you know, we realized that some people, patients were overtreated, that they could go longer. But on the flip side, obviously, we know that in the real world, patients just don't come in for injections. And I think your take on the community learning about risk and benefit of each agent is crucial, right? I think we have to balance risk and benefit of anything we use, and we're lucky to have safe drugs with a comparable safety profile in ranibizumab and aflibercept. So thanks again for a great discussion here. For the audience, we are taking a short break now, and we'll be back with a case in a minute. Please don't go anywhere. Hello, everyone. Welcome back from the break. Now, in this portion, we are excited to have Dr. Justus Garweg present a case for us.
Thanks, Arshad. I'm presenting a very long-standing case, a 78 years old, healthy, and newly diagnosed patient with neovascular AMD and advanced cataract, as you may see from the pictures below. Visual acuity was very low in his right eye because of fibrovascular scar, and was compromised in the left eye due to cataract, but also due to his macular disease, as you can see at the image on the bottom line left. In the next image, you see there's a staining of the scar in the fluorescent angiography of the right eye, and there's some leakage, though there's a low contrast due to the minimized contrast due to cataract in the left eye. You see the OCT images, you see the severely destructed macula on the right eye, and some fluid detectable subretinally and subpigment epithelially in his left eye. So this patient received monthly or almost monthly injections of ranibizumab from 2007 on. and he was not stable, as you can see in his left eye, which is stayed after cataract surgery. So the contrast and the signal noise is much better than prior to that cataract surgery, but vision has not improved very much. It was maintained at 2032, whereas reading vision went down despite visual monthly injections. So at this point, after 3.5 years of monthly injections, we decided to inject additionally intravitreal corticosteroids because aflibercept was not on the market. We learned that this did not add to the benefit of this eye, and we went on with monthly injection. Here you can see the situation prior to switching to aflibercept, which is another 2 years later, or 1.5 years, a severe pigment epithelial alteration in his only left eye, a visual acuity which is still reasonable with 20/40, but complete loss of reading vision even with magnifying glasses. At this point, aflibercept was marketed, and we decided to switch to aflibercept with a significant intraretinal fluid. And you see already after the first aflibercept injection, fluid completely resolved, and the patient was absolutely dry. Visual acuity did not improve that much, and this is experience with switching. Normally, if you switch a patient, you aim not at improving vision, you aim at achieving long-term stability, which was the case here. But this patient came back and said it's a miracle because he was back to reading with magnifying glasses and was very happy with that. After further 2 monthly injections, in terms of a loading phase, the patient was put on 6 weekly intervals, and obviously these 6-week intervals were his individual limit of extension, as you can see with the recurrent intraretinal fluid temporally to the fovea. His visual acuity has remained stable over several years, and then you see what happened after 12 years after switching to aflibercept. The macula was completely dry, and we managed to keep it dry with, or plus minus dry with 6 weekly intervals. But at the end, visual acuity dropped to 20/60, and reading vision was lost. And this is basically due to macular atrophy, which could be along with the underlying disease, and namely with the fibrovascular scar under the retina, but also with the treatment intensity needed here. That has to be discussed. So at this point, I have to say the patient was very happy with switching, and maybe if we were able to switch him today to brolucizumab, we would come further with extending the intervals, but we would not escape the problem of biological aging. Recall the patient was 78 years when he made his diagnosis, and he's meanwhile 92 years old and still requiring treatment to maintain some spatial vision.
Thanks, Justus. That was an excellent case. Really highlights that AMD, neovascular AMD, is a lifetime disease in most patients. And you can see how you control the disease so well, but the atrophy process obviously was affecting the patient. So Seenu, question for you, looking at the case Justus presented, I mean, it's essentially a patient who has one good eye and they were switched to aflibercept. What are your take on switching a patient that only has one good eye to, let's say, brolucizumab, based on the data we have currently?
I loved Dr. Garweg's case. There's so many points to discuss in this case, a lot of learning points. One thing I took away from the case is the importance of having more than one therapy in your toolbox. He tried corticosteroids and, switched to aflibercept, and he did all sorts of things for the well-being of the patient. And this is what we do in our daily practice. It's all a risk-benefit ratio, and we have to decide, is doing 30 anti-VEGF injections of, whatever it is of your choice, and not drying the fluid, is that less harm than some ultra rare adverse event from a drug? And this is where the art of retina comes into play, and hence the title of this whole discussion is that there's an art here that takes a lot of clinical practice and discussion with our colleagues and understanding clinical trial data and translating the clinical trial data into our daily practice for the benefit of our patients. But the point that I took from this case is the importance of having multiple tools in our toolbox. And not all therapies are perfect, and a lot of pipeline therapies are not going to be perfect, but that's our job. That's what we do as retina specialists, is to balance the risk-benefit profile in any given patient. So whether it's a patient with one eye or a patient with both eyes being treated and the treatment burden is too high, or the frequency of visits are too high, this is what we do, is we tailor the therapies to benefit our patients, or to individualize the therapies in our patients.
Those are excellent points, Seenu, and we are lucky to have multiple options in our toolbox, as you said. Peter, any thoughts on the case, the beautiful case Justus presented, and also what is your experience with intravitreal corticosteroids in desperate cases of insufficiently controlled neovascular AMD?
I must say, Arshad, that in the early days of anti-VEGF therapy, I had considered and on a number of occasions added corticosteroids, but to be honest, I never found them too useful. That was sort of, I think, a leftover from the days of photodynamic therapy, where we found that intravitreal triamcinolone had some utility, but I think in the anti-VEGF era, I think their utility is relatively limited. I mean, this is a great case that Justus presented. I must say I admire not just his perseverance, but the perseverance of the patient. Looking at those OCTs, it's surprising how good his vision was. I have patients like this as well, whose vision with OCTs, that look very similar to that, is quite poor. And in situations like that, it's a lot harder, I think, to keep the patient motivated, keep the patient coming back. I mean, I do believe, and I think there's good evidence to suggest that ongoing with treatment is useful and worthwhile, but sometimes it's hard to motivate a patient with poor vision whose vision has deteriorated slowly over time. After 12 years of therapy, I must say, with virtually monthly injections on a number of different agents, there aren't that many patients whose OCT looks like that see 20/60. I mean, if it weren't for the obvious response that you demonstrated with switching therapy, I would have thought that some of those cysts that we see are degenerative and don't necessarily represent disease activity. But the fact that they go away with switching therapy suggests that there's obviously ongoing disease activity.
Those are great points, Peter. I think the treatment burden issue is real. Even in patients with good visual acuity, sometimes they just get the injection fatigue, as we call it, and I think it takes a great physician to motivate the patient. So congrats, Justus. You did a great job. If I'm having neovascular AMD, I'm coming to you for treatment, and I wouldn't mind living in Switzerland also.
Thank you.
So one last question for you, Justus, followed by Seenu and Peter, is there's a lot of discussion about contribution of anti-VEGF therapy to development of macular atrophy. So I think for the audience, tell me what are your consideration or thoughts on, do anti-VEGF agents really cause atrophy, or we are treating neovascular AMD while the dry AMD is progressing and causing atrophy? What are your thoughts on that?
Well, that was one of the reasons to choose that case, because it gives us very much insight into what is going on. Recall, this case had more than 100 injections in 12 years. This is the ideal case to test the hypothesis of atrophy linked to treatment. If there were a case, if there were a correlation between treatment density and atrophy, then he would definitely have developed atrophy at a much earlier stage. And you must not forget that the biological grounds for developing AMD, be it dry or neovascular, is age. And this case dropped in at an age of 72 years. He's 78 years. He's 92 years by now. And that means his biological grounds have significantly worsened. So that's really important.
I think that's a really good point, Justus. I think the point is that if all of us live long enough, we may all end up with atrophy. Seenu, what are your thoughts on anti-VEGF and association with macular atrophy?
Look, it's a, first of all, I agree with everything Dr. Garweg mentioned, and it's a very fun academic debate. It's been going on for over a decade, and it's a very fun debate to have. But the truth of the matter is, number one, there's conflicting data, and number two, that, what are you going to do? Not treat a patient with wet AMD out of this concern? And so for me, I don't think the anti-VEGFs are causing geographic atrophy. I think that we have an underlying disease called dry AMD that's left untreated, and that's progressing with time. And we do a great job keeping the wet AMD component under control. So that's all I think it is. It's a passage of time. And even in the CAT study, I think it was an artifact, and it's probably outside the scope of this course to talk about why that is. But I think it was an artifact that we saw in the data. So in my opinion, it's a fun academic discussion. It doesn't change the way I manage. I don't undertreat for the concern of geographic atrophy. And I think we still have to continue to treat the wet component of the disease, regardless of whether this is a true phenomenon or not.
Maybe I may add to that, that if you look from a patient perspective, patients don't care about an atrophy in 10 years. And the thing is, if they develop atrophy due to uncontrolled neovascular activity, they will lose their vision within several months. Whereas if you treat successfully, they will have a time of years or even decades to develop that atrophy. And this means they have a chance to develop compensatory mechanisms for their vision loss. So if they get rapidly rid of their vision, they will be helpless. If they slowly lose vision, they adapt to that situation and still maintain their independence. And this is very important in my feeling and what I get back from my patient in that situation.
I think those are both excellent points, Seenu and Justus. I think what you're saying is that a patient suffering from neovascular AMD, if you don't treat, they will lose their vision very fast. And if you don't control the disease, they're going to lose their vision, versus worrying about atrophy, which may come down the road. And, we have all had patients, depending on the lesion type, they may not have atrophy down the road. So I think the point is that we need to treat the wet component, and we are lucky we have many agents that are in clinical trials, in late stage clinical trials for dry AMD and geographic atrophy. And we hope that we have those agents approved so we can slow down the process of atrophy while controlling wet AMD. This is a wrap up of this episode. But for the audience, we have more episodes that are forthcoming. And the next episode will review phase 3 data and real world data with wet AMD treatments. Also, please check out the images from the cases on itube.net. Thanks again for listening.